And now, welcome to week 8. I think this is probably my favorite, besides cardiac, of all the conditions, because it is so different from med-surg adults, okay? Now, you will find that I have done both adult ICUs and I've also done pediatric newborn ICUs. So I've got this very well-rounded experience. You'll hear me tell you, in adults, you'll see this, but children, this is what makes it different. And it sort of will help you with your med-surg class. Now, this week, we have due that clinical pediatric assessment. We do have that pediatric assignment exam, which is a case study, and it's 50 NCLEX questions. So see if you can get that done. Next week, you'll take a quiz on today's information, GI, GU, okay? Now, I did put that GI, GU matching in the chat box. I've also put it in your announcements, and I will, usually right after class or shortly after class, I will put up your recording and I'll put up the Kahoots that I do, and I will put up again that matching. In fact, I'll put the answer sheet up so that you'll have both of them. I developed that GIGU matching from going to your book and going through it and picking the major topics that were there. Okay, and you'll see it if you went through the book. Those topics are those highlighted areas. So it really gives you all the information that you do need, okay?
Megan.
Now, I usually do not do a break, just to let you know, okay? But if you need to get up, go somewhere, get something to eat here on camera, okay? No, there is no quiz this week. It is next week, all right? A question just came up, just to let them know. Where was I going? I completely broke my chain of thought.
You were just saying how we don't take a break, and if you need to get something, get something.
Thank you, Courtney, very much. You know, I've got so much on my mind. I have Thanksgiving for 50 people coming up. I'm shopping right after we leave here. So I'm like, anyway, it's okay. Biggest Thanksgiving I've ever had, but it's going to be great. It's my family and my daughter and her new husband's family. So it's going to be a lot of fun. It's Cubans and Jamaicans all together. Can you imagine? With me, the gringa, the one American girl. Anyway, I had to share that. But anyway, if you need to do something, go ahead. Let me know. Now, I always do need to see your face on camera. Like Maria, I can see the top of your head. That can't be like that. I know Dr. Brown is popping into classes this week, looking for people, making sure when we're on presentations, looking for you. So I'm going to warn you, she might pop in. So just be aware, okay? All right. I'm going to do the PowerPoint first, and then it's like a couple of minutes. So you have like 5 minutes in between that in order to get the Kahoots up. If you need to get up at that point, you can wait till then. Anytime you have a question, please stop me, ask me. I don't mind questions ever, because if you have a question, I'm sure somebody else has a question. And my goal is to make sure that you understand the information. Anybody who knows me and the way I teach very simply. I make it in an understandable fashion. I don't think you need all the big words. You need to know how to use the concept. And that's the way I do teach. So week 8, let's start with GU. Now, GU and urinary tract infections go hand in hand in kids, right? They're learning how to get potty trained. You know, they're soiling in their diapers. It's going up in wherever hole that they can get into, right? So it's the most common of all. It's very difficult to keep these children from getting urinary tract infections. So when we start seeing fever, we start seeing symptoms, it is taking care of it and treating it. Now, uncircumcised boys tend to have a high incidence because it covers the head of the penis, right? So you've got all that schmegma building up in the foreskin, goes through the urethra, goes down into the bladder, urinary tract infection. Um, Uncircumcised boys, how do we take care of that? Well, just pull back the foreskin, clean it daily, and it's what we should be teaching these parents. And the other thing always, tell them whatever the diagnosis is, make sure the child finishes all the antibiotics. You could almost treat it, get it treated, and then you don't finish it, and then we could get that infection again. And we don't want to hurt kidneys, okay? Especially young kids, their immune system aren't as strong as ours. So how do we look at kids? How would we know? Well, any child who's potty trained is incontinent, something happened there. If it's not stress related, it's probably urinary tract. If we're smelling their urine and it doesn't smell good, or you see them keep running to the bathroom, and sometimes you'll see some redness on a female down there, you'll see redness going on. Those things are going to tell you. We need to teach our parents all about this. Let them know what to look for. And we know that all kids should wipe front to back, but they get to that point where they close the door and they don't want you to watch them, right? So do we know if they really did? Um, Another thing with adolescents, it is said now, we don't want our adolescents having sex, but let's say the reality of life. Adolescents will do what they want to do. We all have done it, right? Make sure that if they are that child, that adolescent that is apt to get urinary tract infections, if they urinate right after intercourse, they will decrease the chances of urinary tract infections, believe it or not. So we get a child, and they could be from infants all the way to adolescents and adults, right? Urinary tracts are common for everybody. First of all, we need a urine culture and sensitivity. Now, on premature infants, and premature infants can get urinary tract infections, what we do is called a suprapubic aspiration. Right above the symphysis pubis bone, we clean it, use sterile gloves, sterile syringe, and a needle. And we go the needle down and pull out a half an ml of urine. It's about all you need for a culture. Usually these children are on some sort of medication, sedation, so we do plan for pain control there too. We do percutaneous kidney taps for those resistant that we can't figure out what's going on. Maybe that infection is lodged up into the kidneys. We can put catheters in, wash out all of the fluid and debris, figure out what that is. An ultrasound's looking at structural things, because is there strictures, something refluxing going on? Voiding cystourethropy is done on those toddlers, preschoolers that with frequent urinary tract infections, we want to see, is it structural that's going on? And they do it as an outpatient procedure. They put in a catheter, they sedate them, give them to the x-ray, they put in dye, and they see if it goes up the ureters into the kidneys. And that's a voiding cystourethropy. And then we let it all go and we see, where did it stay? IVPs, intravenous pyelography, that's for your kidney stones. And then we could do a renal scan again, looking for any sort of anatomy problems. Now, one of the things we do in GU is renal biopsies. We do them for many different reasons. It could be looking for infection, looking for tumor, it could be anything. Now, it is through the back, because the kidneys are in your back. I mean, you have to go through all your intestines to get way back to do any kidney surgery. So they're placed on their abdomens. They will be pre-medicated, especially your younger children. They will not lay still for this. These children, we do need to prepare them the way they'll be positioned. We'll assist those physicians doing it. Always vital signs before and after. Medicate as they tell you to, and make sure that these children are comfortable. Post-renal biopsy, they take a needle, they go through the skin in the back, and they get a piece of urine and a piece of tissue from that kidney. There is problems with oozing of urine, oozing of blood. So we need to be on bed rest for 24 hours. or sometimes they put a bag on it, a sandbag, a weighted sandbag to keep pressure on it. Now, if it's leaking and they're on their bellies, it's going to leak into the peritoneal cavity. You're going to see them in pain. You're going to see them get redness and tenderness. And because you've touched a kidney, you always monitor intake and output. Now, infants are small, so sometimes they need to look inside there. They might get that incision. Now, I've quickly mentioned this obstructive uropathy, if there's any obstructions going on. The bladder is known as a vesicle. It's a vesicle that holds liquid. You have ureters that come from the kidneys, that the kidneys get the urine, goes down the ureters, and feeds up the vesicle. Every place where there's a connection to a different thing, there's valves. And there could be some sort of valve malfunction, and it could reflux. There also could be kinks in the tubes going down so that urine can't go down. And this can cause problems with urinary tract infections. This picture's in your book. Again, you can look at that. Now, nephrotic syndrome, and I'm going to say something 3 times, has nothing to do with kidney failure. It is not kidney failure. Your kidneys are working. It's not failure. The kidneys say, protein, bleh, I don't like you, and gets rid of it. So what would you see? It would be protein in the urine, right? Because that's what the kidneys do to say, get rid of it. You're going to see proteinuria. Well, protein is that albumin in your intravascular space, in your blood. And we know protein in the blood has to do with how we administer medications, right? If we don't have a lot of protein and the medication can't hop onto it, there's a lot of free medication in your blood system and blood levels can go high. So one of the things we watch for, you're going to see low albumin or protein in the blood. It also causes hyperlipidemia. And because there's no protein in the blood, body likes an isotonic state. Now we're hypotonic in there. It's going to spew fluid out interstitially. These children with big puffy eyes, tongue, they'll just be really swollen. So edematous everywhere. These children, it's for life. This is an acute, not just an acute. This is a chronic condition that they'll have to be dealing with for life, okay? We know that they're immunosuppressed, so risk for infection. Their mouth is all swollen, tongue is swollen, they're biting their cheeks. It hurts to eat, loss of appetite, right? Now, any patient with fluid that's being retained, you always, salt restriction, fluid restriction. Makes sense, doesn't it? So we'll be doing this for children too. These children, because they're for life, we need to support the family. We need to tell the siblings what's going on. There should be no salt shakers on the table. And you know, kids, they like to pour it on. So the family needs to understand it so they can help this child. So our goal is to stop and decrease that excretion of protein. We also want to get rid of all the fluid that has been retained. And of course, because they're immunosuppressed, prevent infections. Now, when you look at fluid balance, adults or children, what do you do to monitor fluid balance? Intake, output, daily weights. If its output is more than input, we know we're getting rid of fluid. And if our daily weights are going the numbers down, we also know that we're getting rid of that extra fluid, besides just looking at that child. Now, acute glomerulonephritis is caused by a strep infection that wasn't completely taken care of. It's like rheumatic fever, right? It's another strep infection. These are the 2 diagnoses that can occur when a parent doesn't give a child a complete course of their antibiotics and does not go back and get follow-up to make sure that that infection is gone, okay? What do you see with glomerulonephritis? Well, it attacks the kidneys. You stop urinating. You're not urinating. Where's the fluid go? You're edematous and hypertensive. You also will see hematuria and proteinuria going also with this. So the prognosis of this is good if we get it good soon enough, and as we treat that strep infection. So you can see how antibiotics are going to be given for a longer term here, a month, 2 months, depending. It all depends on the physician checking the ASO titers, anti-strepelicin titers, that looks at strep in the body, and making sure that that's going to be negative, okay? It can turn into chronic disease if it's not treated properly. So again, glomerulonephritis is kidneys. How do we manage edema? Daily weights, intake, output. And because it's peritoneal cavity, we do abdominal girth measurements. And again, low sodium, fluid restrictions, and they're also susceptible, so preventing infections. Now, Wilms tumor, I've seen one in my career, and I had just done some sort of module that we did for keeping our licenses up or something. And I did one on Wilms tumor going, I've never seen that. About a couple months later, I see this little boy came over from Haiti. He was 3 years old and he spoke no English. He was put on a plane after the earthquake in Haiti. We had gone down there, the hospital that I worked at, and we said that he needed to come to us because we thought for sure it was Wilms tumor. And they got a religious group to sponsor it, get him there. They picked him up at the airport, brought him immediately over to the ER. I'm the triage nurse right there. All of the records are in French. The kid speaks French. I don't know what's going on. And these people had no clue who had picked him up. They are non-medical. So I got on that child's level somehow, gave him a sticker, let him see what I was going to touch him with. He just sat there and he helped me, and I listened to him, and then I palpated his abdomen. The left lower quadrant had a softball size, little, huge tumor. And I went, Wilms tumor. So it is that 3-year-old. It is boys. It's exactly what I had there in front of me. So what do we need to know about Wilms tumor? Well, they're extremely fragile, these tumors. That means too much manipulation can cause metastases to just spew off and go into the peritoneal cavity and travel. So do not palpate that abdomen. From the moment I touched that and felt it, I took my hand off immediately, put a note on the chart, and said, please do not palpate abdomen. And I let the physician know who was going to take care of him in the ER so that he knew what was happening also. They do not do any pre-op biopsy, because if they did a biopsy, they've opened it up, and guess what they did? They spewing metastasis everywhere. So what they do is chemo, radiation, or both, one or the other, and then they go in through all of those intestines, all the way to the back, and they take that tumor off that kidney. They do very well.
Why wouldn't they just go through the back?
They
Because
go
of,
through the front. I don't know, but there are pictures. I believe I also have them on your review that you'll see also. It's like they open up that belly wide open and to go in. And that's a great question because I've wondered it. But
well, I know that in adults they'll go through the back to get to the kidneys. So that's why I didn't understand why it wouldn't be that way with children.
well, I know that post-operatively, I mean, maybe the method of treatment has changed. I'm not sure. But postoperatively now we got to watch for megacolon, for, bowel not moving because of that manipulation. Also checking for urine problems. So GI and GU will be monitored really close afterwards. Thank you for that question. Makes me think. I like it. Renal failure. We have acute caused by something, and chronic, usually they're born with it, or they've had so much kidney damage, they've damaged their kidneys. So acute renal failure is all of a sudden the kidneys stop working the way that they should. They either decrease drastically or they stop working. And we know kidney failure, we worry about electrolytes, potassium, acidosis, all of these things. Now, one of the things, believe it or not, is dehydration can cause acute renal failure in children, not in adults. So children that are out running and sports, they should be maintained with hydration. That child with GI problems, our priority is always hydration, because dehydration in children is extremely serious, and can cause that kidneys to stop working. Now, chronic renal failure is when at least 50% doesn't work. And we know it progressively gets worse, deteriorates, and they say it's called uremia. Now, why chronic renal failure? Well, I did clinicals at the GU floor, and there was a dialysis unit there. And I asked the nurse, why are so many kids on dialysis? I don't understand. And the nurses said, one of the things that we do see is some cultures do intermarriage of families, first and second cousins. And because of that, they're seeing problems with kidney failure, believe it or not. I said, okay, so that's the hereditary component. We know it could be because of malformations, which is just basically, always killing those kidneys, chronic pyelonephritis, infections that are not taken care of, right? Making sure that we take all of our antibiotics. And then, of course, chronic glomerulonephritis could have been due to strep, but now it's a chronic. And of course, anything, anaphylactic purpura, lupus attacks any organ, so that can cause chronic renal failure also. Now, with chronic renal failure, what is our goal? Well, number one, this kid is going to be strapped to a machine as they're older. We want to try to keep those kidneys working as well as they could. We know that we have to make sure their fluid in them is good, that they're not over with fluid them, electrolyte balance. We know that erythropoietin doesn't work the way it should, and we know their hemoglobin hematocrits are going to be low. They're going to be getting blood transfusions or erythropoietin injections, right? Because we do have that synthetic type. And again, trying to make these kids as normal as they can. I saw so many things that these children did. They made signs and needle points, and they made little books about their thing that they were sharing in this kidney dialysis room to share with other children as they come in. And I liked that the kids were helping other kids. Now, when you're an infant and your kidneys don't work, one of these conditions, prune belly, is one of the conditions. And the kidneys just don't work good, and it needs help. Well, they cannot do hemodialysis. The flow of blood in and out causes such turbulence that it will rupture the intraventricular, it will cause intraventricular hemorrhages, brain bleeds, and it can cause cognitive delays. So we can't do that. Also, in adults today, we're not going directly to hemodialysis. We're allowing them to have peritoneal dialysis at home. Okay. And it gives them that freedom of at night while they're sleeping, children and adults to be able to get this done. I had a very good friend go into kidney failure at age 65, and she went to peritoneal dialysis, and it gave her the days to do what she needed to do. Now, peritoneal dialysis in children, what is it? What does that mean? Well, you've got a tube, like looks like this right here, goes into the belly. And what you do is you have a machine, and it's got some what we call diastolate or liquid, whatever the nephrologist has ordered, whatever he wants, electrolytes and whatnots in there, sometimes glucose also. And it goes into the belly and it sits there. It's called a still. Might be in an infant 100 mLs, which is actually quite a bit on a little infant. Then after it stays there for 20 minutes, it drains. So when you instill it and it stays there and then drain it, it's one cycle. Usually they do at least 8 cycles every night. And then you're going to say, well, how do you know how much urine came out? Well, if you did 8 cycles and you put in 100 mLs, it is 800 mLs you expect to come out, right? And it goes into a Foley catheter bag. So you measure that urine, and the difference between 800 is urine output for the day. Now, our biggest concern is opening that up and infusing infection bacteria into the peritoneal cavity. If you do that, you lost your kidney, right? And that is called peritonitis. Now, you ever see a change in the color in that peritoneal fluid coming out, you need to call the doctor immediately. And you need to start antibiotics. We need to save our kidney, our peritoneal cavity. I have seen this done for 2 years on a little boy at a clinical site where I worked, and he finally got a kidney transplant. It's doing great. But that child never had an infection. And the dressings this mother put on the peritoneal tube, amazing. And I'm a little OCD of neatness, and this mother probably was as good as me. And that's saying a lot for her.
So what
Oh.
age does a kid qualify for dialysis? Because you said like when they're so little, it will do more harm than good. So what age do they start dialysis?
You know, there really is no set age. It depends on circumstances, but a child less than 1 year could not because of the flow into the brain. The brain does get more, it can tolerate it better as they get older. But usually you try to hold off as long as you can. I mean, 3 and 4 years old is better than, 1 year old. I've never seen them down to 1. Usually they're that older child that can be able to do it. But it takes a lot of due diligence from parents, and healthcare providers. And many of them have home health nurses come in to do it at night that the parent can't do it. So, it's up to us to keep this, their only type of kidney free from infection so we can use it. I've never thought about that close about how, but they have to be older where the brain is not as fragile. And that's about after a year, I would say.
Okay, I was just curious.
No, it's a great question. Thank you. So what best describes acute glomerulonephritis? Anybody?
The B?
B.
Yep, it occurs after a strep infection. So how do we treat it? Antibiotics. All right, let's go into GI. Now, GI's got a lot of stuff that we never heard of in the adult world. So I'm going to try to point out those key things that will clue you into what's going on. Well, remember, GI is mouth to anus, okay? So it starts with eating food and it goes down and, you evacuate it. Nutritional disorders are a big thing in children due to conditions. Just think about cystic fibrosis, fat vitamins, right? Vitamin imbalances due to that, mineral imbalances, and then not being able to tolerate foods, and you'll see that growth failure, failure to thrive type things. We know that cancer decreases your want and need to eat. HIV, same thing. Sickle cell, again, we're losing these vitamins. Cystic, and then low birth weight children pose a problem because they need nutrition, but they need it in smaller quantities, right? So we need to know how to pack in smaller quantities the nutrition that they need. Now, celiac disease doesn't care if you're an adult or a child. We know that it's the small intestines, and we know that it has a problem with fat absorption. It has to do with gluten foods. It just irritates that small intestines. So, how do we treat celiac disease? Well, no wheat, rye, barley, one more. Wheat, rye, barley. I'll keep going, I'll remember it. But today, what's great, they've got rice products, rice flours, and we could get them, you know, those cakes and cookies and stuff that they wouldn't be able to have. Food allergies is something we start to see when we start feeding our children at 6 months. And the reason why we wait 4 to 7 days in between introducing a new food is to make sure that they're not allergic. Well, some kids will put on a rash. Well, that's easy to detect, right? But sometimes it's vomiting, lactose intolerance, or it could be diarrhea. It could be rashes, a big diaper rash occurs. And sometimes underneath the arms, underneath the neck, you know, like irritations. It could be that subtle. So parents need to really be looking at that. GI dysfunction causes lots of stuff. If you're not getting nutrition, you're not going to grow. Cognitively, you're not going to be as aware. You'll be spitting up, you could be regurgitating that little bit. Nausea, vomiting, diarrhea, constipation, abdominal pain, all of these things are problems with our GI tract. Dysphagia, it means you can't eat well. There is a syndrome called DiGeorge syndrome, and one of that is the swallowing thing, and speech therapy has to help them learn how to suck and to swallow or eat a spoon and swallow. And we know fever burns up liquid like crazy, right? So fevers, we need to replace those liquids. Now, dehydration. I told you this is one of those big things in children. What is it caused by? Well, it's that insensible fluid loss, like with fevers, sweating. It could be all of a sudden your kidneys are just putting out urine, vomiting, diarrhea, of course, ketoacidosis, and burns. Of course, that's going to cause fluid depletion and dehydration. Now, I love these two pictures. When you look at the picture up top, and it's an infant, and it looks like they're just sitting there. Look at the fontanelle on that infant, and even the one on the bottom. It is sunken in. That is a child at rest, sitting there. It should just be flat. It is sunken in. Infants are easy to tell dehydration. But look at the color of the nose and the ears. They're pale. Again, it's showing you. Now, what would be the next thing that I would do looking at that child if they were brought to me in the hospital or into the doctor's office? I'm going to listen to their heart rate, and it's going to be elevated. In dehydration, heart rates go way up. So that's why you know these vital signs that we've given you handouts regarding, you know, different vital signs for different age groups. You know, an infant, brand new neonate, 140 to 160 is their heart rate, normal. If you see it 200 at rest, is it a fever or is it dehydration? I mean, it's very easy to look at it. We take a blood pressure, it's going to be low. What else do we see when we see even older kids with dehydration? Well, capillary refill is going to be prolonged. You're even probably going to feel cool hands and cool feet on them. Mom's going to tell you they haven't urinated in 6 hours. Absolutely normal. And then the one thing that hurts me is seeing a little infant crying and no tears come out. And they are crying, but there's such a lack of fluid, they don't have enough for tears. So, treatment. Well, it depends. Is it vomiting? Is it diarrhea? What are we going to do? But we know fluid needs to be given because I've already said dehydration is extremely dangerous. So we're going to be starting an IV. We're going to be drawing lab works with that IV, and we need a basic metabolic profile. We want to see where our glucose is and where our electrolytes are so that we know what we're starting at. We know that initially we're probably going to give boluses of fluid if the baby condition allows us to, and to try to catch them up with their fluid as quick as we can. Remember, whenever you have a bolus, number one, you never give potassium with a bolus unless you know the potassium level. And number two, you never bolus with any solution with dextrose, adult or children, same thing, okay? And the other thing is, if you don't have a potassium level back, but they void, now you can put potassium, in the IV, because, a lot of times we know the potassium level might be low. When vomiting occurs, giving them antiemetics, whether it's, the ODT or IV, Adunstron, we'll be giving that. We do everything to try, rest the belly, make sure that we stop the vomiting. Measuring intake and output in these cases, very important. I mean, how many times of diagnoses before here, I'm talking, how do we measure fluid balance, intake and output? Well, let's look at it. Urine, stools, vomiting. I've never measured sweating. I've never seen one that much, but if you needed to, you could put a big diaper underneath, know what it weighs before you put it underneath, and then take it off and weigh it. And you're going to see how many grams is how many mLs of urine that is there. Vital signs are always there. A child at rest that's not crying, looking at those vital signs, and we can see it's elevated. We'll know. Skin turgor, mucous membranes, and then in the hospital, if we have these body weights, daily weights, we can see, are they gaining or are they losing? And then I love, as I said, fontanelles are easy because you can look at it and say, oh, that's sunken. That kid is dehydrated. And then we know if the brain isn't getting fluid because it's so dehydrated, you might have a confused child, a sensory alterations. Now, there's all sorts of diarrhea. We know antibiotics, what do they cause, right? Many of them are diarrhea, so we got to be careful with that, making sure that they're getting enough fluids. But it could be acute or it could be infectious or non-specific. It's just sometimes children get diarrhea. It could be a new food you introduced, right? So how do you manage diarrhea? Well, diarrhea without vomiting and the child is awake, you're going to give oral rehydration, unless it's extremely severe. But usually diarrhea, we will just feed them Pedialyte, Gatorade, Powerade. We'll start there with fluid replacement, because again, we don't want to see dehydration. And slowly we'll reintroduce the diet, of course, keeping away from spicy and pepper. And I always say that years ago, when I first became a nurse, they used to do what we call brat diet. We don't do that anymore, but
some hospitals still do the brat diet.
They still do it? Okay.
Mhm.
Well, where I was from, they just never mentioned it, but it's a great thing to start. Bananas, rice, applesauce, toast. Applesauce blocks you up. Apple juice makes you have diarrhea. So those are things that I would teach. Here in South Florida, the rice, okay, everybody wants to give rice to their child because, the Hispanic population, rice cures everything. And chicken soup with rice in it is what they like to do. Now, constipation. Children do get constipated. Some are from birth and it's just a chronic condition, but sometimes it's something that all of a sudden happens. Now, one of the things children can do and control is their bowels. I have seen them go 7 to 10 days with no bowel movements. and the abdomens are large, and now they're complaining of pain, and they're still not stooling. So children control this. Usually stress, something's going on at home, or maybe they want attention. I don't know exactly, because all children are different, but they come in. We do an x-ray, and the whole bowel is like lit up with stool in them, and we have to give them an enema to get them going. Now, we don't like to give enemas to children, but in the case of 7 to 10 days, we got to get it moving. We don't give laxatives, we don't give enemas. We're just going to increase their diet of roughage as much as we can. And, Miralax is also one of the things that's prescribed, but that's about, it was like a Metamucil for older people. Now, when you have a newborn who does not stool, there's several different things it could be from. It could be that there's an atresia, which means A, without, no opening. That means the intestines is clamped shut at a certain area and stool can't pass. Or stenosis, a narrowing, and it's hard to get down there. Hirschsprungs, I'm going to go over that in a little bit. Hypothyroidism, if you have a child, you didn't know that there's possibility of thyroid, they'll be checking thyroid hormones. And we know that infants especially need thyroid hormones for cognitive awareness. They don't get it, they will be delayed. And then, of course, meconium plug or ileus, cystic fibrosis. So these are things we'll be looking at. Usually children are born and they stool right away, and it looks like that black gooey tar stuff. That's usually what you see soon after. But if you don't, we're going to go looking for what's the cause. Now, constipation in infancy, and they do happen. As I said, sometimes it happens. Sometimes, as in the older child, they can stop themselves from urinating. We know that formula-fed babies have more incidence of constipation than breastfed babies. It has to do with the formulas, and even breast milk, they actually consider it more of a clear liquid that they'll give. So we know formula-fed infants. Now, there's all sorts of interventions. There's all sorts of things grandma's taught you do. But the one thing, don't ever give your infant honey before a year old. It can cause big, big problems. The pediatrician might say give them a little apple juice or give a little prunes earlier than usual. But again, we're not going to be doing enemas or laxatives in the infancy. We'll do very natural things to try to get them moving. Now, children can get ulcers. You have little children that are the worriers. And because they're the worriers, they get ulcers. Usually we medically treat them with diet and, ridinidine, which now is your Pepcid, not your Zantac. And prognosis is good. Again, it's not just giving the med if it's something to do to an emotional relation. Having that child talk to someone is always good. Now, hepatic disorders, hepatitis. What does the liver do? What does it digest? Bile, digests fat. The liver's not working for whatever reason. What do you think is going to happen? You're going to digest carbohydrates, you're going to digest proteins, but the fat is just going to stay there. You're going to see, and this is the highest caloric, right? Protein and carbohydrates are 4 grams, right? And when you get to fats, it's 9 grams. So we know that fats are heavy laden in calories. So these children not only are going to have abdominal distension because fat causes gas, but you're also going to see a lot of muscle wasting on them. So in hepatitis, we want a low fat diet with higher in protein and carbohydrates, because you have to still take over that fat calories that they can't get. Okay, here's that Hirschsprungs, which is part of that, no stool at birth. Well, Hirschsprung's is usually the distending colon, and there's no nerves in it. Aganglionic, no nerves. So no nerves, there's no peristalsis. It sits there. The just swallowing mucus, normal digestive stuff, goes down there and distends and distends. And because there's no nerves, it doesn't hurt. What will you see? Well, occasionally, because if you look at the rectum, the bottom of it, sometimes a little bit sneaks through and it squirts out in little ribbons out of the tiny little rectum in the bottom. It's like using an icing little thing and putting on decorations on a cake, like little ribbons that you might see there. We know Down syndrome, this is one of the things that they're also prone to. So no stool. We think it's Hirschsprung's. We've taken an x-ray. Well, what are we going to do next? Well, we need to do a biopsy to confirm that there's no nerves there. And of course, a barium enema to see where exactly it's at. Now, this is a non-useful piece of intestines. There's no nerves. It doesn't work. They need to cut it out, but they will put a colostomy. Now, usually within the first year, they'll reconnect it, usually. So it's, yes, the baby goes home, it's gonna have a colostomy, but they do later on connect it. And again, when stuff like this, they like to get it connected before potty training so that they can deal with that.
My oldest daughter had a bunch of problems with constipation when she was 7. It started when she was 7. And so we had to go to the Moores down in Orlando, and they did a colonoscopy, anal rectal manometry, and a colonic manometry, something. They were testing for all of that, and it was really, like, I hated seeing my kids go through that, but it was interesting to see, like, the balloon in the anus and them teaching her how to, like, bear down on it to see if there was any kind of nerve damage or nerve missing
Wow.
or anything.
Constipation, we think it's benign, but it's not always a benign thing. It can be like, yours, Christina, could be something very serious that needs special treatment to it. So
Right.
something we shouldn't
And
ignore.
they ended up just diagnosing her with chronic constipation because they couldn't figure out why. But she actually had to start doing, and she still does it, but she had to do something called a peristeen treatment, and she was having to do it every day. And they use it a lot for kids with spinal bifida, I think. But it's pretty much she was having to give herself a water enema every single day. She's now 14 and only has to do it twice a week. But yeah,
Wow. Wow. Wow, that's unusual. Yes, yes. As I said, usually they don't like to do enemas and they don't like to do laxatives, but you've done all the treatment and yeah, if that's what they say, of course. But that's the outlier. That's the different one. But thank you for sharing that. So acute appendicitis, adults, children, McBurney's point, right lower quadrant, rebound tenderness. We know that our goal is to get that appendix out before it bursts. These children, they come in, you can see them a mile a minute when I worked in the ER. Usually they'd walk, many of them. It's usually that, 5 to 9, I would say is that big age. But don't mark me down as that's the age, but it's what I remember the most. They'd be holding their right lower quadrant, they'd be bent over, and they'd be limping on their right leg. And you're like, that's what it is. Now, as long as they're in pain, they still have the appendix there. It has not burst. We do an ultrasound, we find it. One of the things that when I used to see those children looking like that, I would tell the parents, please do not give your child anything more to eat or drink. I'm already preparing in my mind. I know they're going to surgery, and you want to have that stomach rest. Usually it's laparoscopic. They go in, take it out. Sometimes it's in the morning and they go home at night. If it's done later in the day, they'll go home first thing in the morning, unless all of a sudden the pain is gone. And if that pain's gone, that means that appendix is burst, and now we have really bad peritonitis. So all of that material from the area between the small and large intestines, the cecum, just bursts into the peritoneum and creates those intestines to be angry, angry, angry. So how do we treat it? Well, these children will not eat now because those intestines are angry. We need to let those intestines rest. You are going to put them on IV fluids and, of course, IV antibiotics for that infection. Now, because those intestines are so angry, we put an NG tube down and we try to even those gastric juices, get rid of them. We try to keep the intestines as empty as possible because we want them to rest because they're angry at this point in time. Always, always monitor pain control. These children should be up, out of bed, coughing, deep breathing. They can go and walk around in the halls. We can clamp off NG tubes while they do those things. But again, preventing post-op complications. And the only way to do that is before we want them to do like incentive spirometry, medicate first. Always remember, children, they're not going to tell you they're in pain because they're afraid of needles, right? And most pain control immediately post-op is going to be all IV. So those children don't know that. So make sure that they are in good pain control and that we do get them up out of bed. Now, one of the things we forget about is that peritoneal cavity is all inflamed and infected. And when we're done doing even a laparoscopic and closing the wound, it's dirty wound because even the inside of the wound is dirty. So we have to be concerned that it might dehisce. So checking that wound, making sure it's intact is very, very important. Okay. Now, intussusception, very interesting thing. These are young kids. The youngest one I've ever seen is 5 months old, and only one in my career. I usually see them at 2 or 3 years old. And this child would present usually in mother's or father's arms, screaming, and their legs are just banging up and down. The intestines suck into each other. And you know those intestines are full of nerves, and it swells and it hurts. Now, what would I check? Well, their mommy's arm, I'm going to touch their belly and I'm going to feel it. It's going to be rigid. But if they're having a diaper on, I'm going to look inside. Many times you'll see a little bit of jelly. It's called currant jelly stool with maybe some streaks of blood in it. And that's just what gets forced out of the end when it sucks into each other. And this is a sudden. Many times you'll see them say, yeah, it happened earlier today, but it went away, but it happened again, so I brought them in. You can see it will go in, come out, go in, come out. That is the harder one to diagnose. Well, if they're in pain and get them to ultrasound, we can find that it is, that intussusception on that child. Sometimes if they have a stool, we know there's nothing more we can do because it's showing patency of that intestines. How do we treat it if it stays in there? There's 2 different ways. We can either go to radiology and they say it's a barium enema, or I've seen air enemas by the radiologist. They put a tube up into the anus and they pump air under fluoroscopy and they watch it pop out. I've seen that many times. I've heard of barium enemas. I've not seen it done that way. And if we cannot reduce it that way, they'll go to surgery and have a colectomy. A piece of their intestines will be taken out. Sometimes it's the parents waited too long. The swelling so much is so tight, they can't pop it back out. Now, Meckel diverticulum, it is the small intestines, and it's a remnant of what we call the fetal mesenteric duct. It's like a piece of skin tag. And in it is a big blood vessel. And sometimes it rips. And this blood vessel bleeds inside the intestines. So we will going to see painless rectal bleeding. Sometimes there'll be an obstruction with it, but many times it's painless rectal bleeding. We're going to go and they do this radionuclide test. They can go and pinpoint where it's at, but what they need to do is take that diverticulum out, and then they do really well. IBS, mouth to anus, right? Ulcerative colitis or Crohn's. We know that IBS has to do with the inflammation of the bowels. Usually it's a nutritional type of treatment. Many times it has to do steroids, and sometimes you'll see them put on biologics to help the body from attacking its own intestines. Short bowel syndrome. Many times children have incidences where a large part of their bowel dies and they have to remove it. Well, I'm going to tell you about Jessica. Jessica was a cardiac child. She was 8 months old, had her second stage hypoplastic heart, and in the recovery, they started slow feeding her with a tube that went from her nose into her intestines called an ND tube. And all of a sudden, the belly looked big. And we found out she had necrotizing enterocolitis. This is when there's not blood supply. It's due to hypoxic episodes, and who else knows what all, but usually there's some sort of hypoxic episode. And the bowel dies. And then, of course, stuff can't get through. And it keeps dying until you get it out. Well, this girl, her small intestines, they removed like 48 centimeters of her intestines, which means small intestines, she had hardly any absorption area. So she's not getting nutrition. You can see that because your intestines, small and large, are there to suck up nutrients, right? So that your body gets what it needs. So this girl would be on G-tube feedings during the day. They did let her eat if she wanted something by mouth, but she had a Broviac at night where she got hyperal and lipids, and she was a smaller child. She was one of the last children I saw when I left the hospital where I worked at. Her and her triplets, her brother and sister, came in, and they came looking for me. I don't even remember why she was there, but they had to see their nurse, Betty, and they called me Boop. And they had to come see me, and the mother hugged me, and the girl was small, but she was living a pretty decent life for everything that had gone on with her. So short bowel, not enough space to absorb what you need. It's all about nutrition. They're not getting what they want. How do you maximize nutrition? Now, sometimes the stomach doesn't get closed inside the abdominal wall. It's open and the stomach is born on the outside of the child. That is called a gastroschisis. And I've seen actually quite a few of these, believe it or not. And these children, of course, they're in the newborn ICU. They have their stomach outside, so the surgeons put a good sterile dressing, we call them teepees, on them, and we hold them up, usually something hanging over an IV pole to hold them up straight so that the intestines, the stomach, can go back into the abdominal wall. After a couple days, they come in every morning and they try to open it up and squeeze a little bit more in there, and eventually they can close it. Now, everything's attached. It's just that it was born on the outside. Our biggest concern is infection, right? Because it's born on the outside. Now, hernias. Hernias can be anywhere. They can be on the diaphragm, worst thing of all. That means it's up into your lungs and one of your lungs isn't working and the other one's pushed over, so that's barely working. So respiratory issues, usually this is at birth that we see. These are very sick children. Sometimes you see like that little umbilical hernia. I love taking my finger and pushing it in and out when they're nice and soft and squeezy, right? If it gets hard, red, painful, it's incarcerated. That needs surgery. But if you're pushing it in and out, having fun with it, it's fine. And it doesn't hurt them at all. Just a break in the wall and the intestines comes through. And I know a lot of premature infants, you might see inguinal hernias that have been intubated long time. They cough and you'll see inguinal hernias. Malrotation and volvus are two different sort of conditions where the intestines, they're twisted on each other, and it causes severe pain. And again, it could cause perforation and peritonitis. It's similar to an appendix, but due to different reasons. So we have malrotation, has to do with the intestines are rotated around an artery and it gets clamped off. And volvus, it's twisting itself and now blood supply is gone. So they're harder to diagnose. You know, these ultrasounds, CAT scans you have to do. Now, in OB, you were taught to take a rectal temperature at birth, right? Because you want an accurate temperature. Well, you're also checking to make sure they have an anus. Not every child is born with an anus. So they will have to go in and do a colostomy immediately. And then what they do is they try to, multiple surgeries later on, try to get it reconnected to an anus and make it work for that child, okay? Another thing as nurses we need to look for, because not always the physician sees it, is peritoneal fistulas. It could connect the urine to the stool to the bladder. So seeing if the proper body excretions are coming out of the proper place. And you will see sometimes stool coming out of the vagina. You know there's a problem. Now, we've done diarrhea. Here's vomiting. Well, there's different sort of vomitings. Well, if we have a child who's vomiting, first thing I'm going to ask, is it dribbling or is it across the room? And you can aim it. That's what I want to know first. And I'll tell you why as we keep going. It could be, you know, bilious or not, so yellow-green or not. What do we do? Well, you know, if you're vomiting, you're usually nauseous too. Now, if this child is vomiting, who's having elevated heart rate, decreased blood pressure, sunken fontanelles, this child's going to get an IV and, of course, always a metabolic profile, and we'll be getting a bolus of fluids, okay? But if it's a child awake and alert, we can give ODT Zofran, wait, and then slowly introduce some fluids because they're not severely hydrated yet. We could do that. But if they're profusely vomiting uncontrollably, it's going to be an IV. I told you this dehydration extremely serious in children. You know, children put everything in their mouth and they eat everything. One of the things that I've seen them eat the most is actually Flintstone vitamins. And as long as they don't have iron in them, it will just be coming out in their urine, because what vitamins you don't need, it will just come out. One of the concerns is older buildings where they had lead paint. You know, if you're from the 50s, 60s, you're building windowsills. You know what, the kids go up and they just suck on them, right? And they chew on them. And if it's lead in it, they could get lead poisoning. So it's something to look out for. Now, GERD, esophageal reflux, very common in children. This is where all of a sudden you have a little of vomit coming out, little squirts, not across the room, just they eat and then they vomit a little bit. An older child can have reflux, adults also. And what you're going to see is, because that food's going up the esophagus, you're having mini aspirations. So you're going to have a chronic cough. And it's going to burn. So it's abdominal pain. And it's that heartburn. Now, usually with reflux in children, and, you know, the infants, we're going to be doing, you know, thickening their formula or breast milk with some rice cereal to hold it down. we might introduce the Pepsid or any one of those GI meds that for adults, kids can take them too, but on a dose for children, milligrams per kilogram. We do have that ability to do that. Now, if it's just keep going and going, and this child, no matter what you've done, what meds you're on, you've burped them well, you haven't overfed, you sit them up, you even have them sleeping, sitting up, and they're still vomiting, they may need a surgical treatment called a Nissen fundoplication. If you ever looked at any patient, adult or child, who's had a gastrostomy tube put in, you will see gastrostomy tube with fundoplication. What does a fundoplication do? Well, it brings up the tip of the stomach and stops you the ability to vomit. So now you're not aspirating, right? It keeps the food down. And now in the smaller children, it's giving them the nutrition, because nutrition. You don't have nutrition, they're not growing, and cognitively, they're going to be delayed. So Nissen fundoplication is that last surgical treatment for GERD. Now, you've heard me say, did you vomit this way or across the room? Well, hypertrophic pyloric stenosis, ages 3 months to 3 weeks to 3 months. Very small children. And these children are vomiting. So, first question, are they dribbling or across the room? They tell me that forceful across the room. First thing I'm going to say is, please do not feed your baby anymore, because they're just going to vomit again. You can literally take a child with pyloric stenosis that's vomiting, point them across the room at the garbage can, and see if they hit it. I'm saying it's that forceful. It's, the feet are going to be splattered and everything. It is quite intense. Now, once I hear it's across the room, told them don't feed them, put my hand up underneath their xiphoid process, and you will see a little olive-sized mass. And what it is in the stomach, there's a pyloric valve that empties the stomach in the duodenum, and it becomes all thickened and muscular, and it's an osis, small little opening, hardly anything goes down. And because of that musculature, you're going to feel an olive, or I call it a marble. You're going to feel it there. So we do an ultrasound, we find it. NPO, as I said, right away. Of course, infants, you can't leave them NPO more than 2 or 3 hours. So giving them fluids with a little bit of dextrose and getting them ready for OR. They go to OR and they cut open, called a pylorectomy, of that pyloric valve. They open it up, and then these kids are good. Next day, we start out with clear liquids and slow, small amounts. And then we feed them into eating normally, and within 2 days they go home. And these children usually do not have long-term complications. Cleft lip, cleft palate, one side, both sides. It is a child who's born, and if you've ever seen a cleft lip on an infant, it's quite hard to look at. And parents have a hard time looking at their infant you can just see their gum there and this opening until we can fix it. Now, what do infants like to do? How do they explore the world? Through their mouths, right? They want to suck, they want to swallow, they want to breathe, fingers, they want to explore. So it's important that we get this lip fixed so that they can suck and explore the world the way that they should. Now, the lip is usually done within 2 to 3 months, and a plastic surgeon does it to make sure the lip, there's not crooked when they grow up. This is from your book, and it shows you all the types. Now, if you have the palate also open, they do that a little later, 6 to 12 months, 8 to 12 months, the later half of the first year. and they'll go in and they'll close it up. And these children, our biggest concern is going to be, what do they want to do? How do they comfort themselves? How do they eat, right? Well, look at that little bottle on the right. Some parents try to breastfeed. Very difficult because they have to squeeze their breasts as they're on the breast, because they don't get a suck. That suction doesn't happen because of the hole there. So you're squirting and they're sucking it in. Some parents will still try to do it. There is this bottle. It was made by a mother many years ago of a cleft lip child. And that top area is soft and you can squeeze it. So you turn it over, the milk fills it up, you sit that child up good, and slowly as they suck, you push just a little bit, and they're sucking, and now they're getting all the satisfaction they need. So we know growth and development, they have to suck, it's part of them. We know nutrition, if they're not getting it, they're not going to grow. Cognitively, they're not going to be there. So it takes a very patient family to take care of this child. Esophageal atresia, tracheoesophageal fistula. Why did that do that? Let me go back to it for a second. So, one thing I've seen too, one was a cardiac who had this, so it was doubly complicated, but esophageal atresia, which means you have an esophagus and without, which means it doesn't connect to the stomach. So how are you going to eat? You're not. Now, sometimes you have your trachea has a fistula and it connects to the esophagus. So, and sometimes they're together. So anything that's swallowed goes down into that esophagus where it doesn't have anywhere to go, backs up, goes across the fistula, and it goes into the lungs. So now you're worried about aspiration. Aspiration. Anything you give this child in the mouth is going to go directly into the lungs, and now you've created aspiration pneumonia. These children at birth will be coughing and hacking because everything's going in their lungs. They're looking like they're aspirating. So elevate the head of the bed on these children, have suction at the bedside, nothing in their mouth. Give them a pacifier because they still need that growth and development. So with tracheoesophageal fistula, NPO, nothing by mouth. These children are usually normal. It's just their connection isn't right. So they need, before they go to surgery, because of these mini aspirations, IV fluids and antibiotics. That's prophylactically given so that they don't causing the aspiration pneumonia, okay? And then they do surgery and they fix it, and of course slowly introduce their food. But the big thing with this one is aspiration pneumonia, little aspirations. Any questions? A lot of interesting stuff, a lot of things you haven't heard in the adult worlds with this one.
So you said you've only seen 2 of those TEFs before?
Yes. Some of them do it and then they put like what we call a spit pad in. They connect it to the outer part of their chest. And then later on, they go and fix it, like that cardiac child. She came back at 8 months and had it done because
The reason, well, I don't know if it was the same thing, but my little great nephew was born in September and his esophagus went straight to his lungs. But they did a surgery and now he's fine.
they usually want to do it at right away. But
Yeah.
this one girl had a spit pad, it was called. And we just put a gauze on it and we just kept changing it like frequently, because it would drip there instead of going into her lungs. But yeah, but she had a cardiac issue. So cardiac took priority over that part. They just made it so that she wouldn't be aspirating. All right, I've got a Cahoots that's pretty neat. Anybody needs to get up and run to the ladies' room, men's room, kitchen, just let me know. Just go ahead and we'll start. Have you all done Cahoots before? I want you to know my class is very competitive. They love to win. So let's see who wins today. Go to Kahoot.it or take that little sign there on a picture and go right to it that way. That's what Jose just did. You know, I just learned that this quarter. I've been using Cahoots for 5 years. I didn't know you could take a picture on the phones and go to it. I'm a little technology challenged here. It's okay, Rayford. It looks like we're going to be done right at 5 or 5 after that area. So that will make up for the breaks that we didn't do. And I know all the time I give back to you, I know that you do appreciate it. So
I have a quick question.
absolutely.
I have company coming over around 4:30. I expected to get off by then. Would it hurt if I cut off about 20 minutes early? Or do I need to stay on till 5?
You'll be okay, Mackenzie. Your attendance so far is great.
It's
I
5
Yeah, I'm not-
understand
Eastern,
that.
Mackenzie.
What?
It's 5 o'clock Eastern she's talking about.
Oh, okay. So it's 4 o'clock our time. Oh, okay. Sorry.
I keep forgetting I have to mention that. Yes, it's Eastern Standard Time.
Okay. Okay.
Forgive
Good.
me.
Sorry. Central
Forgive me.
time 4, so I'm good. Okay.
Mackenzie, you'll be good even if you had to leave a little earlier. Your attendance is perfect. So no worries. All right, I'm gonna go get going. I wish you all good luck. Let's see who wins today, right? Week 8, pediatric GIGU. A lot of interesting things. A multi. All of the following are symptoms of dehydration in an infant except. Any of those excepts? Or all of them? Or one of them? You know, one of the things that Hesses and NCLEX loves to talk about is dehydration and being able to look at fluid balances. And you're going to have a decrease in urine output. Dehydration, you're not urinating. Elevated heart rate, decreased blood pressure, dry, pale skin, tenting in the skin, weakness, tiredness, lethargy, confusion, all of these things, cold hands, cold feet, sunken fontanelles. I mean, all of this stuff is something that you will see.
I think what messed us up is you said all of these are except.
Okay. All right. I apologize. What is priority treatment for a child with dehydration due to profuse vomiting? So you have a kid, what's your priority? She's dehydrated because she's vomiting. I mean, when you look at a question, tear it apart, look at it. Dehydration, vomiting, oh, profuse. Okay, IV fluids. She is not going to be able to have those oral electrolytes. If it was, vomited once, but this is already saying she's dehydrated. You're going right to IV fluids. What is the treatment for an infant with diarrhea lasting for 4 days? So we know vomiting most of the time is going to be IV fluids, right? Usually with diarrhea, it's going to be oral. I had a picture with an IV there to try to throw you off. I did, but now we've learned diarrhea, feed them, give them food. If you don't give them liquids, you don't give them food, how is that diarrhea going to tighten up, become regular stools? Think of it that way, okay? What acid-base imbalance may you see with a child that's having profuse diarrhea? You know, a couple HESIs ago, there was 4 questions on ABGs and acid base. So I infuse these into my Kahoots to have you think. So if you're having profuse diarrhea, diarrhea is all alkaline. All of those digestive things in your small intestines are alkaline. So when you have diarrhea, it comes out the end, it's all alkaline. What is left? Acidosis, right? Acid is left. So metabolic acidosis is the answer here. A multi. If an infant has not passed the meconium stool within the first 24 to 36 hours, what would you assess for? Everything but an electrolyte imbalance. You know, we're trying to figure out why they haven't stooled. I mean, in Hirschsprung's, remember the other name is megacolon, and it is an intestinal obstruction, which it doesn't allow. The thyroid, you need that hormone to stool, and then cystic fibrosis is another one that you'll see with no stool. Deficiencies of vitamin D causes. Well, what does vitamin D do for the body? Does anybody know?
Helps absorb calcium,
And calcium is used for what?
bones.
There you go. So the answer would be rickets. Very good. You pulled that apart perfectly, Kirk. Thank you. Yes, you are Mr. MedSurge. I agree.
We just learned it today.
Oh, multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? What are you going to do? You know, in this Kahoots, I'm going to hit you a couple different ways with vomiting, diarrhea, IV fluids, PO. What am I going to do? Well, if they're not eating or drinking and they're vomiting, diarrhea, we know that we have to give IV fluids. That's the number one. Now, always, it's very important that basic metabolic profile. Don't forget about that. You will not give anything to eat or drink until you administered an antiemetic and given a chance for that stomach to relax. And then it wouldn't be sips of water. It'd be sips of Pedialyte or sips of Powerade or sips of Gatorade, okay? Water does nothing. There's no content in it. A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? So remember, appendix ruptured in that abdomen. It spewed all this caustic, material into the peritoneum. The intestines are angry. So we're not going to put any post-op patient on complete bed rest. We're going to medicate them, get them out of bed. That's part of post-op care with incentive spirometry, etc. We're going to put them on IV antibiotics, NPO, right? And that NG tube to keep that intestines empty because the intestines is not happy right now with all the stuff that's hit the outside and irritated it. And because we've closed the site and it was dirty in there, the chance of dehiscing are huge. So assessing that, not bad at all there. Passage of urine, usually at night in children who should have voluntary bladder control. What is that called? It's called enuresis. Now there's, I can't cover everything in a PowerPoint, so there's two things I want to mention with this cahoots. Epispadias and hypospadias are males. And at birth, epispadias, the urethra doesn't come out to the tip of the penis. It's on top, anywhere on top. Hypospadias is on the bottom. It's not out here. The goal with this is to be able to correct it before they become potty trained. This child, you need the foreskin for a plastic closure. That might be a problem in the Jewish faith, right? They want to cut that off as part of the, their culture. So something they cannot do. Post-operatively, what they do in this surgery is they open the penis and fillet it open. General anesthesia, guys. And they take and make a hole that goes, from the bladder now to the tip of the penis. And they put a tube in there to keep the lumen open, close it, and use that foreskin to close the penis up. I've seen it. I've seen the tube in there post-operatively. These kids do very well with it. That tube is usually left there for 7 to 10 days and they pull it out. You do nothing to that tube. Put it inside a diaper so you don't urinate all over the place. That's the only treatment for it. So epispadias on top, hypospadias on the bottom. A hole where it shouldn't be. A multi. What is Hirschsprung's disease? So it's a congenital absence of the ganglion cells. That means nerve cells. They're not there. There's no feeling. It doesn't work. It's also called a congenital aganglionic megacolon, which means it's a bowel obstruction because of no nerves. Very good. A multi. When teaching parents about Hirschsprung's disease, the nurse would include what? Well, we know it has to do with we're going to remove that intestine. It's two-stage surgery. We put a colostomy up and then we connect it later on. And after that's done, of course, this is a child that's had intestinal surgery. We're going to be monitoring the bowels of them. And again, we don't treat children with laxatives and enemas on very rare cases, do we? Okay. Which was already said earlier. But we usually, no, we don't. We don't want them to become the habit of that. What types of stool would an infant with Hirschsprung's disease have? Everybody say it goes down to that little anus. What would it look like? These are your ribbon-shaped stools because it comes out and it squirts almost like one of those cake decorator things. And that's the way I can describe it because it does. It looks like a little ribbon like that. Not like you're going to decorate your cake with it. What is the condition that occurs mainly in children when the intestines telescope into itself? It sucks in. The problem is when it sits there so long, it swells and then it can't come out. That's the big thing with that. And it is called intussusception, okay? Intussusception is a hard word to spell. I have hard word trying all the time. I always have to look it up, but it's when it telescopes in. And these children, you'll see them screaming, those legs going. You know it before you even look at the child what it is, believe it or not. Gastroesophageal reflux disease, GERD. What's that? So the stomach, all of the food, whatnot, goes up into the esophagus and it burns. And remember, older children, adults, you're going to see them doing that coughing and that feeling that heartburn going on. Younger children, we just need to try to figure it out with meds and maybe some rice cereal in the formula or the rice or the breast milk to help keep it down. IBS involves what? Inflammatory bowel disease. And that's any part, absolutely any part, mouth to anus, IBS. What would the nurse be looking for when a patient has a Meckel diverticulum? Remember, that's that little outpatching thing that has a large blood vessel in it in the small intestines usually. And we just go in with surgery, correct it, take it out, and the child's fine. But it is what we call painless rectal bleeding. Maybe there's slight discomfort, but it's really nothing significant. Painless is what we usually call it. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? What would you do first? Mom tells you all of this stuff. What are you going to look at first? I want to know where that pain is. Is it right lower quadrant? Is it in the belly button? It'll depend on how I'm going to treat that child, right? If it's a surgical issue, I want to make that child NPO right away. So finding out where in the abdomen it is, doing an abdominal assessment first. What would the nurse expect to see in an infant with biliary atresia? This is when the liver, the duct that connects to the duodenum, it's not there. So no liver bile is getting to the common bile duct, not aiding in any digestion. What would you see? This is where you don't have the bile there, the color. Remember, not digesting fat. So clay color stools because of the color, and abdominal distension because of the fat. Always fat in the body creates abdominal distension. Gives you a lot of gas, fat. What structure of the mouth can be impacted by a cleft lip and palate? And it's that everything. It's the lip, it's the hard palate, soft palate, all of it. And it could be all of it or bilateral it. It could be, or just a lip. A lot of times it's just a lip. Cleft lip repair is typically done when? And there is that Aberman bottle being used, and you can see her fingers are there just slightly pushing on it so that we can get that child that's satisfying that they think they're sucking and they're getting their formula or milk, breast milk. It's usually between 2 to 3 months. And cleft palate is done when? The repair? I mean, when cleft lips are done properly, you can barely even know that they were done. And they really are particular about getting them done plastic and pretty for those children as they grow. So cleft palate, 6 to 12 months. It's older. It's the lip first, then the palate later. Esophageal atresia. What's that? And that means there's no stomach. That it doesn't connect. There's no connection. I mean, usually the body has the stomach there, but the tube doesn't connect it. The esophagus does not attach. Remember, there'll be vomiting. They're going to be aspirating. NPO is the treatment with IV antibiotics for those mini aspirations you'll see. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So because you cannot eat, but because you still have oral juices, it's going to be going and having many aspirations. Cyanosis, choking, coughing. Olive-sized mass is pyloric stenosis. Current jelly stools is intussusception. Bilious emesis and frequent stools is a gastroenteritis, okay? A multi. Neonate with suspected tracheoesophageal fistula. Nursing care should include so we're not feeding this child. You feed it, it's going to go right down in the mouth, right into the lungs, and now you have aspiration pneumonia. You want the head of the bed elevated, NPO. You want suction at bedside, and you're going to be giving IV fluids because they can't eat, and antibiotics because even though you're not feeding, you still have mucus, and it's going to create some mini aspiration. So antibiotics is to prevent any pneumonia there. And you're going to give them a pacifier to suck on. A 5-year-old child complains of an epigastric pain and a persistent cough. What would you suspect? Epigastric pain and coughing. What is that? That is reflux in the older child. Very good. What is ranitidine used in children with peptic ulcers disease? I mean, now it's famotidine, which is your Pepcid. All it does, it reduces gastric acid production. ulcers, acid, it tends to eat the skin more inside the stomach. So you decrease that, there's going to be less chance of it irritating the stomach and the area that's already broken down. Doesn't neutralize, it decreases. Signs and symptom of a hypertrophic pyloric stenosis. So hypertrophic pyloric stenosis is projectile vomiting and that olive-sized mass right there at the midline, okay? Those are the things. And you know something? These kids are constantly crying to eat because nothing's going down, okay? So it's never a poor appetite. They want food. Signs and symptom of a hypertrophic pyloric stenosis. It's projectile vomiting. As again, they are hungry. It's not going down. As soon as they vomit, they want more. They want more, but because they're not getting their nutrition. Preoperative treatment of pyloric foods. Make them NPO, start IV fluids. We are not feeding this kid. They're just going to vomit again. What does the celiac disease affect? Where is celiac disease? And it's your small intestines, okay? In the small intestines, that's why it has to do with nutrition and fat. It's the small intestines. If you have celiac disease, what would you eliminate from your diet? Wheat, rye, barley, and oats. Oats, the ones that I forgot earlier. And again, remember, rice now is a great substitute. I know that the supermarkets around even have gluten-free written everywhere. Can you imagine 20 years ago, they didn't have that. So, you know, parents had to figure out what to do for their children. But today, it's just so easier to take care of these children. A multi. Vitamins that children with celiac disease are prone to lose are, remember, celiac disease cannot absorb fat. That's why we give them a high caloric, high protein diet, and we decrease the fat because they're have abdominal distension and a lot of abdominal pain. So your fat vitamins are all but C. C is water soluble, okay? The other ones we can replace. We can give them vitamins. So, but remember, vitamin C is water soluble. It's not fat soluble. What foods would you select for a child with celiac disease? Wheat, rye, barley, oats cannot have. So look at that and tell me which one you would give. So the one that didn't have wheat, rye, barley, and oats is number one. Fish sticks is covered with bread and macaroni is part of that. French toast is bread, and then roast beef does have bread, so only the bacon omelet. Phimosis. It's one of the things I didn't cover in lecture. Something that happens with boys that are uncircumcised. And what happens is the foreskin is so tight, you can't pull it down. And this will create a problem with boys because we know we need to pull it down to clean it, right? Because of the schmegma that's sitting there and infections. You know, my grandson had phimosis. I could not pull the foreskin down. So at 1 month old, we had to go get him circumcised because we wanted to pull it down. We wanted to be able to clean it. So it was done then. So phimosis is too tight. What's a hydrocele? This is painful, and this is boys. And this is something that is treated with usually a shot of Rocephin, believe it or not. Sometimes the symptoms are incontinence and just pain, but it's just fluid around the testes. So they come in with testicular pain, and it hurts. It doesn't mean adults can't get this. Adults get hydroceles also, and it's testicular pain. It hurts, and again, and they could be incontinent, even adults, and they treat just with an antibiotic, usually a shot of Rocephin, ceftriaxone. So what is cryptorchidism? It's another boy thing. So you have a newborn boy, you bring him to the pediatrician, and they do an examination. And one of the things they do is they check that each testicle is down where it should be, right? Well, in this case, one or both maybe didn't come down, you know, but one of the things we have to be sure is make sure that when it's cold, testicles suck in. So we want to make sure that the environment's warm so they're down. So we're getting a true and real examination. That's the one thing that we need to do for that. So you suspect an infant with cryptorchidism. How would you examine this infant? So again, have them in a warm room because a cold room it would suck up and it wouldn't be a valid examination. Very good. A hypospadias. Told you earlier on one of the questions. So now I'm going to ask you about it. It's the ventral side of the penis, which means somewhere, doesn't mean that it's the urethra doesn't come out the end. It's somewhere underneath, and it could be anywhere there. A multi. How is a hypospadias corrected? So remember, we need that foreskin because we flay the penis open, literally, okay? So it's not done under local. This is general anesthesia. They create a tube and they put in some sort of catheter stent in there, close it up using the foreskin. And again, that tube that's left there, the catheter, we don't do anything to it. Just make sure it's inside the diaper so we don't get urine everywhere. But that is a major surgery before potty training. What is bladder exstrophy? Remember with these things is when something's born on the outside, we have to worry about the skin integrity. We need to worry about infection. Those are always nursing priority care. We don't do anything with the bladder. The bladder's connected, and urinates the normal way, but that bladder, we must keep it intact. The skin underneath it and the bladder itself until we can get it back in. What is the priority nursing care for an infant with bladder exstrophy? So we always worry about the tissue integrity, and we also worry about the bladder. Very good. What are the clinical manifestations of nephrotic syndrome? Remember, it is not renal failure. Nothing to do with renal failure. What does nephrotic syndrome say? Protein, yuck, I don't like you, I'm getting rid of you. And protein comes from everywhere, right? So it is hypoalbuminemia. Of course, your albumin, serum albumin is going to be low because that's protein. Albumin, protein, the same thing. And again, you're going to be swollen, these children. So it's all the answers. Children with nephrotic syndrome are often given what medications for fluid overload? Well, think about, you've got extracellular type of fluid going in. You need to pull it intracellular to be able to get rid of it. How would you do that? Well, nephrotic syndrome is all about protein, right? So let's replace the protein, wait about 20 minutes, hit it with a good dose of furosemide, Lasix, and you're going to see the fluid come off. So albumin and Lasix. Good job. That's the hard question. What is used to treat nephrotic syndrome in children? You have your answer right in front of you. So it's prednisone. Prednisone is what done. It's not an infection. It is not just monitoring. I mean, we monitor fluid balance, yes, but we'll give prednisone. It's part of the treatment in acute stages when they're really swollen. A child was admitted with acute glomerulonephritis. What recent illness could validate this finding? And that's the sore throat. Okay, glomerulonephritis, rheumatic fever are all due to strep. Okay, so a recent sore throat could have led it to acute glomerulonephritis. Treatment, treat the strep, antibiotics. What is the priority nursing care of a child with nephrotic syndrome? Remember, nephrotic syndrome is all about fluid balance. How do we treat fluid balance? Too much. Adults, children, don't matter. And it's those daily weights, intake, output. That's all there is. Fluid balance, that's how you monitor it. Why is erythropoietin used in chronic kidney failure? So it helps increase the production of red blood cells. It's a sub-Q injection that is given, and it helps the body produce its own instead of blood transfusions. A multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to the child? Osteodystrophy, what does that word mean? Chronic kidney disease. Osteo is bone. Dystrophy, it means abnormal. So, skeletal abnormalities, growth retardation, and then calcium problems, high parathyroid levels. All of them create these bones and skeletal abnormalities. And sometimes even the bones don't grow the way that they should. It has nothing to do with the uric acid. A diagnostic finding of acute glomerulonephritis may be, I mentioned it 2 times. One of the ways that we can monitor if this is the cause, or making sure that we've given enough antibiotics that the strep is gone out of the body. ASO titer, a positive anti-streptolysin titer. This has to do with strep in the body. And when we see strep in the body and we have the symptoms of acute glomerulonephritis, we know the cause is from strep. And now we're going to treat it. Which complication of peritoneal dialysis is most important to prevent? That's what I want to put in there. Remember, your peritoneal cavity is your kidney now, because the kidneys aren't working. So the one thing that we want to prevent is infection. So it's abdominal peritonitis. And we know some of the signs or symptoms are as simple as change of the fluid color that's coming out, not necessarily redness, tenderness, or fever. That's later. It's usually the color changes first. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? I have a 9-year-old kid who came into the ER, was playing tag, and he was running backwards fast and ran into a trailer hitch. Right at the level of his kidney, had a huge ecchymosis back there. He had fractured his kidney, and one of the lab tests, his potassium was 7 something. So yes, elevated potassiums are showing you something's wrong. He had a fractured kidney from the force of him going into that trailer hitch. So yes, we'll watch potassiums. A multi. What should the nurse anticipate for a child who just had a renal biopsy? And we're sticking a needle in the back into the kidney, looking for urine, looking for whether it's the tissue or for urine, looking for infection. Post-op, post-procedure, what's important? Well, bed rest 24 hours for sure. So no ambulation. No, this is one for 24 hours. You will not. It's like a cardiac cath. No. Monitoring intake output. You punctured a kidney. Very important. And because you want to make sure that blood or urine is not leaking, monitor that dressing. What would you do if the fluid draining from peritoneal dialysis has changed color and is now cloudy? What would you do? I mean, you know what to do, and what are you going to anticipate is another question. So you're going to notify that provider, and you're going to anticipate you're going to be given antibiotics, but you need an order first. And last question. What would the nurse provide to an infant that cannot eat normally? Helping with growth and development. What are you going to give that infant who can't eat? Whether pyloric stenosis, esophageal atresia, tracheoesophageal atresia, they can't eat. The pacifier. Pacifier is one of the most important things. How do children, infants, soothe themselves in their mouth? Put a pacifier, they can self-soothe. Very important concept there. Good job, guys. See how we did today. Number 3, Amber. Good job, Amber. Number 2, Hope. Oh, wow. Look at you, Hope. Number 1, who did it? Christina. Good job, Christina. Abs and a K. Good job. That was a good I like these topics. I think that I make it enough sense for you that you can follow it and understand it. It's just remembering those little type of clues of what symptom has what. What's current jelly? What's a olive-sized match? Which is projectile vomiting? Those things are something that you're going to have to remember. I think with that handout I gave you on GIGU, it's going to help you understand it also. I wish you all a very, very, very happy Thanksgiving. It was a pleasure seeing all of Professor Morris's class. Again, any questions, still come to me. Leave your professor alone. Give her that chance to heal like she needs to. And I will be posting this stuff in a little bit to both classes, okay? Any questions?
I have one about the assignment for